Bangladesh Society of Colon and Rectal Surgeons, BSCRS, welcoming you all to this international webinar. Our today's webinar topic is the art of management of complex fistula in annual lessons from the experts. With the permission of Presidential Chair, this is Dr. Arun Kumar Pal, Assistant Professor, working in Dhaka Medical College. I will be with you for few times. First of all, we deeply mourn the passing of the COVID warriors, I mean the health workers who had sacrificed their lives in war against ongoing pandemic. We recall with immense gratitude to their invaluable contributions. We pray to the Almighty for the salvation of the departed soul and extend our heartfelt condolence to the bereaved family. On Presidential Chair, we are honored to have Professor Mutiur Rahman sir. He is now convener of Bangladesh Society of Colon and Rectal Surgeons, that is BSCRS. Sir actually teacher of our teachers, still working in the surgical era. We can congratulate him. Our chief guest, Professor Konok Kante Borua sir, an eminent neurosurgeon of Bangladesh and also Asia Pacific. Now, serving as 10th Honorable Vice Chancellor of Bangabandhu Sheikh Mujib Medical University, BSMMU. Currently, Sir had again elected as President of Neurosurgery Society of Bangladesh. We again congratulate him. Sir had published more than 47 papers in national and international journals. Our special guest, Professor Abian Khurshid Alam sir, another renowned surgeon of Bangladesh. In current past, he was the head of the Department of Surgery in biggest medical college of Bangladesh, Dhaka Medical College, and now serving as Director General of Health Service. Welcome, sir, and grateful to you for giving us space through your busy schedule. By breaking the rules, we seek our apology that our special guest, sir, will be busy with our health minister. So I just take his special remarks regarding the webinar. Professor ABM Khurshid Alam sir, Honorable DGH, Bangladesh Health Service. Sir.
Assalamu alaikum and very good evening to all the participants here. I would like to thank the Society of Colorectal Surgeons of Bangladesh for keeping me as a guest and allowing me to say a few words. I would like to thank our mentor, especially I would like to say my mentor, Professor Mutiur Rahman, for whom I came to this specialty surgery. From third year, he was my teacher, and what I found in him, the a genuine teacher, a dedicated teacher, a loving teacher, a caring teacher, and up to this time, I am very much blessed with his love and affection. And today's the foreign faculties, Professor Parviz Sheikh, Professor Arun, and Professor Charles. I would also like to thank them. And our panelist, Professor Shahadat Hussain. Actually, because of weird, I could not recognize him at first. That's because there is a new change in this COVID. So many of us, they have changed their facial cutting. And Professor Shahadat Hussain Sheikh, Professor Jahidul Haq, and Professor Abu Tahir. The moderators, Dr. Tariq Alam, Arun Kumar Pal, and Farhana Salam, and all the participants. I'd like to thank all of you and say salam to all. The management of complex fistula as a surgeon, I also faced several times, especially in working the peripheral hospitals. We found that the patients are coming after maltreatment and after complications of the previous surgery. The peoples have got very much misconception regarding the perianal pathology, and they are afraid to go to the concerned doctors or surgeons or specialists. They think that this can be treated by the local Kobiraj in our Bangladesh, they are calling. And sometimes we found that they apply some acid, some local herbal medicines, and these ultimately complicated uh, by their action into the anal muscles and the perianal skins and mucosa, etc. So when they comes with multiple fistula tract or fistula with anal stenosis or fistula with other pathology, it is really difficult to handle it. And sometimes we found that, especially in some areas of the country, the fistulas, we found that tuberculosis is one of the cause. I don't know how much experience the other surgeons have to face regarding this pathology, but in our series, in a medical college, we found that a particular area of Brahmanbaria, Kumilla, and Chandpur, especially the low marshy areas, the peoples from there, they are suffering from this sort of complex fistula. Though we could not find out exact cause, but I think the bad hygiene or some other things could be responsible for this. And management of the complex fistula is always challenging, and surgeons are facing this problem from the beginning. And the new modalities of the treatment, which are coming up, and the surgeons are addressing these things and helping the patients. Uh, I'd like to say that I'm having ill luck that I could not participate all along the session because of my other appointments. You know, the COVID is the more stressful conditions for our health sectors, and we are expecting this in the winter. The incidence of the COVID will be increased, and today we had a long discussion how to combat this situation and regarding the planning of this management of second attack if it increases really what to do, and we are engaged with this. And also about the vaccine, and what we will do if really the vaccine comes at the end of December or in the January or in the February. So we have to prepare ourselves regarding that. For all those public health issues, I have to remain engaged. So my surgical life has been jeopardized, rather I say. I could not uh, go to seminars, symposium, and other things. I have to remain with the administrative job. So I'm begging pardon, and I'm breaking the uh, line of speakers, and I'm privileged rather that they have allowed me to talk ahead of the presentation. So I'd like to thank the Society of the Colorectal Surgeons and especially my professor, my mentor, Professor Mutur Rahman, and all the foreign faculties. Uh, I'll try to again return back. I don't know whether I'd be able to join, but I hope that this session will help us. Our surgeons can exchange their experience. I know both of the Shahadat Hussain sir, one is Shahadat Hussain Sheikh and another is Professor Shahadat Hussain. They are the very expert and eminent colorectal surgeons in our country, and upcoming surgeons are there, Urun and other peoples. And I think in future this discipline will flourish up. And I would like to share one uh, important news that the Bangladesh College of Physicians and Surgeons, the council approved the three new specialties in surgery for fellowship course. One is colorectal surgery, another is the hepatobiliary surgery, another is surgical oncology. So in this respect, I think in future, many colorectal surgeons will come up with the problems, and I hope that they will serve our country and the nations. So Charles and others who are in the screen, I can see. I would like to say goodbye right now. Please pardon me for not being able to stay with you. I have to go. So I am privileged, and again I am thanking all of you just allowing me to say few words, and I can spend. You have spent few moments for me. Thank you so much. Stay safe, stay blessed. Thank you all,
Thank you. Thank you, Khurshid.
Thank-
sir.
Thanks, sir. Thanks, sir, for inspiring talk. And in some aspect, congratulations, sir, for few words, sir. Sir, we hope you will join with us, sir.
Now we shall welcome our distinguished speaker. First of all, our first Yakul. He's the father of LIFT, and he's a professor of Chulalongkorn University, Thailand, and affiliated to Bamrungrad International Hospital. He attained diploma of the Thai Board of Colorectal Surgery and fellowship in colon and rectal surgery from Mayo Clinic, Minnesota, USA. Our second speaker is Dr. Charles B. Shau Tseng. He is a senior consultant and colorectal clinic associates, Singapore. It's our pleasure that he is an honorary fellow in the year of 2010, and from our this dignified institute, Bangladesh College of Physicians and Surgeons. Charles is also a visiting consultant and the Department of Colorectal Surgery of Singapore General Hospital. Our third speaker is Dr. Parvez Sheikh. He is a consultant colorectal surgery and working as a surgical gastroenterologist in a Saifi Hospital, Mumbai. He has undertaken international traveling fellowship of Jaidus, Corija, and Juventus Healthcare. Dr. Parvez Sheikh is synonymous to fistula management in this subcontinent.
Good evening. I'm Dr. Farhana Salam, resident surgeon of Kurmitula General Hospital. Very pleased to be here. I'm honored to introduce you to our panel of experts who are the brilliant minds in the field of colorectal surgery in Bangladesh. Firstly, we have Professor Muhammad Shahadat Hussain, the inspirational surgeon and the respected chairman of Department of Colorectal Surgery in Bangabandhu Sheikh Mujib Medical University. He is also the member secretary of BSCRS. Our next panelist is Professor Shahadat Hussain Sheikh, the illustrious colorectal surgeon who is a pioneer in the field of advanced laparoscopic surgery. Alongside these two leading surgeons, now I would like to introduce Professor Muhammad Abu Tahir, a notable colorectal surgeon, also from BSMU. He is the treasurer of the Society of Surgeons of Bangladesh. Our another panelist was Professor Zahidul Haq, a big name in the field of colorectal surgery in Bangladesh. But due to very unfortunate condition, he is not being able to join this webinar as his sister is in critical health condition and intensive care unit. We are praying for her.
Thank you, Dr. Farhana. Now the session for lessons from speakers. First, I would like
Arun, let me introduce myself. I am Dr. Tariq Akhtar Khan. I am working as assistant professor of colorectal surgery in Shohid Sohrawardi Medical College. Okay, Arun.
Thank you, Dr. Tariq. I would like first Professor Arun Rojana Sakul sir, already mentioned sir's profile. Sir, please kindly start your presentation, sir. Your presentation is lived in the management era of complex fistula in ano. Sir, please.
Hello.
Sir, you can share the you can share the screen, sir. Perfect, sir. Perfect. Sir, you can start, sir. We are seeing, sir. Start.
Let's start now. Good evening. สวัสดีครับ and salam alaikum. My assigned topic is the lift procedure for complex fistula in anal. In this presentation, I have two keywords: the complex fistula in anal and lift procedure. My talk will limit to the only cryptoglandular abscess and fistula. It's part of my personal experience and opinions. Many concepts are new and challenging. So it should be doubt, it should be questions, discussion are encouraged. Do not believe all, but you should listen, and then you can decide later when you have experience with my talk. Generally, except complex fistula anal has a high risk of recurrence and high risk of incontinence. Many years ago, when I traveled on an airplane, I saw a book, a Reader Digest, and the book said, we call things we don't understand complex, but that means we haven't found a good way of thinking about them. So look at the complex fistula. If we look at the BSCRS textbook of the complex fistula, they include all the cryptoglandular and the Crohn's disease and maybe tuberculosis, lactobacillus, they include all. But when we limit to the cryptoglandular, I can draw only high transsphincteric horseshoe configuration in the posterior and anterior location, just in the high transsphincteric groups. And the other one, other group is the suprasphincteric and ectasphincteric of Parks. I think, what it is, the red one? I think many complex abscess and fistula because we have incorrect knowledge, because we have incorrect diagnosis, and because incorrect operation and iatrogenic, because of incorrect drainage of the axis, incorrect insertion of seton, and incorrect fistulotomy. I will explain this. Let's start at the suprasphincteric and ectasphincteric of Parks. Listen carefully, it's Parks, suprasphincteric and ectasphincteric. Nowadays, we never seen, or rarely seen, because it's an iatrogenic. I will explain more in this concern. Suprasphincteric and ectasphincteric of Parks are rare. Most of them are erroneous assessment. It's not true. Most of them are iatrogenic sequelae because of inexpert or because of the no experienced surgeons operate on fistula. Illustration of Parks is incorrect and misleading, and recommend treatment are harmful. If we have time, I will show you. Park in his text, in his paper, he said that fistula were initially thought to be, there was doubt to its track, either because fibrosis prevent adequate access, or because unclear charting of the fistula tract, or in case leg costs. If we look at Parks, suprasphincteric and ectasphincteric, the incident report from St. Mark in the Park paper is supra 20% and ecta 5%. But the later report, maybe in the same period, the suprasphincteric dropped down to 3% and ectasphincteric maybe 3% or only 2%. The same hospital. So there are questions. If we look at a paper from Francis in 1991, in the same hospital in St. Mark, they said that because of erroneous assessment, you can see in the E, the ectasphincteric, finally, the final diagnosis is just transsphincteric. So this is what erroneous assessment. And Eisenhammer, a very famous colorectal surgeon, he said, many complex fistula described by Parks resolve from faulty surgical treatment, leading to iatrogenic disease. He do not believe sphincteric and extrasphincteric, and he recommends primary fistulotomy in acute abscess because he do not believe the high fistula. If we look at this famous picture from Parks, to then into the rectum or to then in the ischioanal, I think this picture is question, because nowadays we know that the abscess or the fistula past the levator is unlikely to happen. So this picture may not correct. I will explain more. In fact, if we have what we call a clinical superlevator abscess, it means that when we put the finger in, we can palpate a bulging abscess above the levator and above anorectal ring. In fact, there are three possibilities. One, high intersphincteric. Second, the infralevator but bulging. You can see only very thin circular muscle, very thin longitudinal muscle. So in this thickness and this thickness almost the same. So this cannot separate. And finally, because of the MRI nowadays, we know that maybe it's happened together. So a clinical superlevator abscess, there are three possibilities like this. And what will happen if we then a clinical superlevator abscess into the rectum? What will happen? You can see, if we then here, we will have a new secondary internal opening. This is acceptable. Finally, we can cut it open, and that's easy. But if we then abscess in the infralevator, we cause trouble because we create an extra sphincteric now. And this also, we create an extra sphincteric. And what will happen if we drain the clinical superlevator abscess in the ischioanal area? Again, if we drain like this, the superlevator high, if we drain it, you look like this. This look like a suprasphincteric, Park suprasphincteric fistula. This is the Park suprasphincteric fistula. But if we then here, it's acceptable. It becomes a posterior high time sphincteric in the posterior. But if we then this, we again, the suprasphincteric and extrasphincteric are man-made. So the abscess, right this or right this, is not accept. We should not do this. We should do this. Because we cannot separate this from this in clinical. So if we then inside here, we cause a lot of trouble. And if we then here, sometimes we cause trouble. So the best way is to then because these abscess have the internal opening posteriorly. So we cut it open, and we cut it open. If you have the abscess, then it's a high intersphincteric. We cut it open like this to anorectal ring. But if we cut it and we cannot see abscess, it means that it's go post-anal space. Then we can cut the post-anal space and like a Haley fistulotomy. Or if you are good enough to do the lift during abscess, I will show you later. That's a good option. Now, come to this. I think Seton is still more widely used for complex fistula. However, it's not easy procedure and may cause complicated fistula. The surgeon put a Seton above the anorectal ring and cause extrasphincteric both sides. So this is infralevator, and many surgeons patient put it for infralevator, then cause the extrasphincteric fistula. This is a fistula, is a seaton from Spain. And you can see, when we do the lift, you can see the seaton here, but the cataract tract is here. So you can have a recurrent if you like it here. If you like it here, you will heal. Another season, you have many season and drainage. Now, I finished my first part. What is the complex fistula? Now I will explain the lift procedure for complex fistula. If we look at the treatment option for anal abscess and fistula, there are many: fistulotomy, seaton, Charles suture, endorectal advancement swab, lift, fifth, valve, FIRAC, many others. But my practice limit to the lift for transsphincteric patterns, fifth for low patterns, and interanal fistulotomy for high intersphincteric superelevator. I rarely use seaton and then endorectal advancement flap. Again, the anterior high transsphincteric, I prefer lift. The posterior high transsphincteric, I prefer lift and fifth. The high intersphincteric superelevator, I prefer interanal fistulotomy or lift. For the posterior high transsphincteric with high this is a complex fistula. In my opinion, this is the complex fistula. We can use lift because we can use interanal fistulotomy and closure of external opening. I show you the case. Let's start at anterior high transsphincteric patterns. Anterior high transsphincteric. In this case, the abscess, the fistula come to here to the perineal space, and then it's cut from one perineal space to the others. This is uncommon. It's have an opening here and then separate to both perineal space. But in this case, very strange. You can see the abscess here cross in front of the transverse perineum to the other cavity here, and only one track here. In the MRI again, you can see pass above the superficial external sphincter is high transsphincteric. We will open this cavity first and cure it. And then we do the lift. You can see I put a probe inside and from outside, a probe past the track here. I cut it open so that you can see the probe. And then I locate the track at the internal sphincter with YQ20. And I locate the other track here at the external sphincter. And this is the post-operative. You can see I always put children in every case. Children is very essential, it's very important in the lift procedure. So you have to put children, and you can see. Now go to the second case. This case, we have the external opening here. The internal opening may be here. It's an anterior high transsphincteric, pass above the superficial external sphincter, extend to ischioanal infralevator. In the anterior that have the abscess in the ischioanal is uncommon. Most of the time it comes from the posterior, 90%. In the anterior, maybe 10%. You can see I put the water in the external opening, but cannot see any water come out because the cavity is quite deep. Then I put a curette into the external opening. And you can see it's very deep, maybe 12 centimeters, very deep. It should pass the elevator, maybe, really deep. Then I examine carefully, and then I can see the internal opening here at 11 o'clock, maybe here. And then I do like the track here and there with YQ20. And then I put a tube then here, put a tube then and suture the lip wound here. And it healed. Very nice in this case. The next case, a lady, he have the Bartholin abscess then 2 years ago. And after that, he have fistula in vagina. And you can see, this is the internal opening, just a little bit above the dentate line. The internal opening is here. And then we put a probe into the internal opening. The probe come out in the vagina. The probe come out in the vagina here. The tip of the probe is here. So we do a lift procedure. This is internal sphincter. This is external sphincter. This is longitudinal. And then I put a probe in the internal and the probe come out here. And then I ligate here. I ligate at the internal sphincter and at the external sphincter here and divide and cut. And you can see, if you observe, see, this is my drain. I use a 2-0 YQ at the drain in the wound. This is another case of a simple but difficult case. This is after lift procedure. I can see that the intersphincteric plane, high intersphincteric superelevator in the anterior. This is anterior at 12 o'clock. So this is the drain that I removed from the wound. This is a drain in the tract. So now we go to the next one, the P4, posterior high transsphincteric ischioanal, posterior high patterns. Again, I will show you how to drain the superelevator, infralevator. In this case, we put a finger in it, bulging above in our rectal ring. But in the MRI, it appears to be the infralevator. Not, if we then here, we will cut through the internal sphincter, the elevator here, we will cut. So what I did, this is in the prone position. I cut it in the Q abscess. I can see no abscess in the intersphincteric plane. And then I get the tract. After I get it, I put the cam into the deep posterior space posteriorly. And the abscess come out. And then I make incision to the deep posterior space. And then I make a lift here. And then I insert the tube then here to the posterior space. It goes posterior space, it's going infralevator here. And it's here very nice. Never have recurrent. The next case of posterior high turn. This is another case of posterior high turn. The tract is very wrong. So I think call out is a good technique for this case. I make an incision here in the middle. And then I call out here. Then I call out here. And then I call out here. It's a short call out. And I make a lift here. So this not very difficult. Open here, call out here, call out here, and call out here, and lift. This is the lift. You can see the tract clearly. You can see? Right at the tract, at the internal sphincter, and like at the tract, external sphincter. And it's here. This is after the operation. And it's here very nice. This is the next case of posterior high transsphincteric. The internal opening is at here. This is in lithotomy position. The internal opening at 6 o'clock go to ischioanal and go anterior to deep perineal. To the infralevator here, is go infralevator here. We can see infralevator here, the tract go from posterior here, go to perineum space here. You can see penis here, perineum space here, but the origin of the internal is here. So from here, the tag go infrared to deep perineal space. Like this.
তোর কাজই তো ওই মোটকো ওজন ওজন
Calling out.
ওজন কমাবি না
This is the calling out. And here and suture here. And then curate here to perineum space here. And then put a soft tissue season here. And it's very nice. The next case is the centric, but after the operation, the patient have scar and sphincter defect and loose stool incontinence. So what I did the lift here, and at the same time, I did the lift. I did the lift here. I repair the sphincter to the lift wound like this. And I put the tube there every time I put, and this is then in the intersphincter crane. Now come to the P5. P5, I do not use lift. P5 means high intersphincter superelevator. What I did, I just cut layer open. After that, marsupialize. This is very useful operation, the intra-anal fistulotomy for the P5. Now we come to the most complex, the P5 plus P4, high intersphincter superelevator and posterior high transsphincter. Posterior high transsphincter, sorry, this one is not correct. So this case, we have the external opening here, another external opening here, but we have a horseshoe superelevator and horseshoe intersphincter superelevator. What I did the lift. I did the lift, like at the track. I put the tube then here, and I make incision here to reach the superelevator and curate from here, curate from here, and curate from here. And in this case here, very nice. Now go to the next case, the last case of my presentation. The patient is a male GM patient, abdominal pain, rectal pain, and septic shock. This is by Shuship Sakip Lungliang 10 years ago. So by the CT scan, you see the abscess in the ischio. This is ischio is free. This is abscess in the ischio. But you see the abscess in the retroperitoneum up to the kidney level. So make incision here, make incision at the flank too, and clean the dead tissue, irrigate the dead tissue, and drain the ischio. Drain the ischio. After that, when the wound heal better, when the wound better, he bring the patient and did the lift. And Shuship told me that he healed very well, this case. So I add some tip for you, tip for better lift. Season is not necessary for our season. Prone position, antibiotic is important. Proper device is important. Understanding anesthesia pattern, very important. Good techniques. Distal tract drainage, distal tract fistulotomy, or calling out, or tube drain. So lift is a better option for complex fistula in my understanding. Oh, I will stop here, but any question I will answer later. Okay.
Sir, question answer, another session, sir. There is a session, sir. Question answer for.
That is question answer session is a letter after deliver speaker, right?
Thank you, sir. Thank you, sir. Thank you, Professor Arun Rojana Sagul, sir, for your wonderful delivery, sir. It was truly amazing, actually, sir, to hear from you. Truly, we believe by invention of lift, we surgeons now extend our courages to do some complex fistula. Thank you again, sir. Now, this is the time for Dr. Charles Bishu is saying, sir. Sir, you know your topics is the role of endoanal ultrasound and endorectal advancement flap in the management of complex fistula in it. Sir,
I'm going to speak to you today on endoanal ultrasounds for complex anal fistulas and abscesses. I'd like to thank the Bangladesh Society of Colorectal Surgery for their kind invitation tonight. This is a ultrasound machine from BK Medical, comprising of two main probes that we use to evaluate anal fistulas. The first one on the top is the 2050. This is a 3D axial probe which captures a series of images in the axial plane, and this is usually combined into a 3D volume image, as you can see here. These images can be then manipulated using 3D software, and we can analyze the anal canal and the fistula in greater detail. The bottom one is a linear array probe, which captures images in the longitudinal axis. And when the transducer is spun around 60-degree manner, again, when reconstructed, you will get a 3D volume image. Of course, the images are much sharper in the longitudinal axis. Very often, we will use a combination of two probes to get the best images to help us assess the anal fistula. This is a 3D image obtained using the 8838 linear array probe. In the longitudinal axis, you can see in this coronal image of the anal canal that corresponds to what you would see in most anatomy atlases. The hypoechoic or line here represents the internal anal sphincter muscle, which you can see is absent in the distal anal canal. This part of the external sphincter muscle is the subcutaneous anal sphincter, and higher up will be the superficial external sphincter muscle, and here the puborectalis muscle. In the axial view, there are landmarks that we will refer to help us identify which part of the anal canal it is. The most common landmark will be the puborectalis muscle, which is represented by this V-shaped or U-shaped sling of muscle in the upper anal canal. Again, the circular black ring here will represent the internal anal sphincter. As you move lower down to the anal canal in the midsection, the external anal sphincter will encompass the anal canal in a circular fashion, and you end up with two rings of muscle. The mostly hypoechoic or whitish band of muscle will be the external anal sphincter. The internal anal sphincter will be represented by this circular black ring. And as mentioned earlier, as you go even further down in the distal anal canal, the internal anal sphincter, and all you are left with is the subcutaneous external sphincter, which meets in front and behind, giving this a elliptical shape. Sometimes it is difficult to distinguish between the hypoechoic abscess or fistula tract from scar tissue, as they both look black in nature. Here, if you have an external opening in the fistula, we could inject hydrogen peroxide, and the bubbles generated in the fistula tract will result in a hyperechoic enhancement of the fistula tract, as you can see over here. So what is the criteria in ultrasound for identifying the internal opening? If we start from this image over here, which is characterized by the absence of the internal anal sphincter, hydrogen peroxide present in the fistula tract near the external opening, you can see that peroxide within the anal sphincter, and here in the mid-anal canal, it contacts the internal sphincter. So contact with the internal sphincter is one indicator of the location of the internal opening. A breach in the the internal in the defect. And of course, where the internal opening is patent, you will see it as a brick in the subepithelial tissue, leading to an abscess or a fistula. Well, the cryptoglandular theory states start within a anal gland, within the intersphincteric space, or sometimes it lies even outside the aplex. But within this space, the infection can track in a multitude of directions. If it tracks within the intersphincteric space out through the intersphincteric groove, then you will have what we call an intersphincteric fistula. Intersphincteric space, it may track catheter upwards towards the supralevator space, and this will result in a high intersphincteric fistula or sinus. Or posteriorly, it can also go into the deep post space over here, and from here it may break in direction to the right or to the left to enter the apex of the ischoanal space, and then ending up to the perianal area. So if we break sides, then what we will end up with is a fistula starting from the deep postanal space. Anteriorly, it can also cause above the superficial portion of the external sphincter and with the anterior high transphincteric fistula, or most commonly, it will cause through the subcutaneous portion of the external sphincter into the perianal space. And here, this transphincteric fistula. The ultrasound image of a patient with a low intersphincteric fistula in the longitudinal view. You can see the hydrogen peroxide hyperechoic enhancement of the fistula tract from the internal opening within the intersphincteric space and coming out into the intersphincteric groove to the external opening. So you will have a gentle C shape or C curve tract. This is a similar image taken using the older 2052 axial probe reconstructed into a 3D image. And as you can see, the longitudinal view is not as sharp as newer linear array probes. This is a picture of a low transsphincteric anal fistula using a linear array probe. Because the external opening is closed, we are not able to inject hydrogen peroxide to elicit enhancement, but you can nevertheless make out the hypoechoic fistula tract cutting across the subcutaneous external sphincter here, and then it contacts the internal sphincter over here. So this will be the presumptive location of the internal round about the mid-anal canal and about the 7 o'clock position. There are a series of axial images starting from the distal anal canal, as shown by the absence of the internal anal sphincter, mid-anal canal, and upper anal canal, shown by the puborectalis muscle. The colored dots represent the vascular images obtained using the 8838 probe in Doppler mode, but with the peroxide enhancement given resulting in the white dot, you can see from the external opening the fistula tract cutting across the external anal sphincter anteriorly to breach the internal sphincter and the subepithelial tissues at the 12 o'clock position. So this would be a low transsphincteric anterior anal fistula. As you can see here, this patient is placed in the prone jackknife position, incision made over the intersphincteric groove, Lone Star retractor applied, retracting the internal and external sphincter. You can see the intersphincteric portion of the fistula tract going towards the 12 o'clock position. This is a female patient with the vagina in front here. And of course, the external opening is 2 centimeters from the anal verge at about the 10 o'clock position. Again, after the lift procedure is done, where we excise this portion of the tract and the openings on the internal external sphincter closed, external tract curetted, the wounds are closed with suture. Now, sometimes the tract will move across the perineum towards the base of the scrotum in male patients. You can see this hypoechoic tract in the distal anal canal here. This is going towards the mid anal canal. You can make out the internal anal sphincter over here. You can see there where it touches the internal sphincter. So the internal opening would be in the region of the mid-anal canal, anteriorly at 12 o'clock. So in the longitudinal view, you can see this is the tract where it touches the internal sphincter, cuts across the subcutaneous external sphincter, and then here it moves anteriorly towards the base of the scrotum. As you can see, we will have to image the perineum with a surface probe, and there is a hypoechoic spot over here. So you can see the bulge over the base of the scrotum representing an abscess. When we incise it, you can drain an abscess and you can put a fistula probe, which leads to this intersphincteric portion, as demonstrated to this exposed lift incision with the external and internal sphincter separated. So obviously we will do the lift procedure over here, curate out the tract and leave this to heal by secondary intention. This is another patient with a high transsphincteric tracking posteriorly and then breaking into the right ischial space. As you can see, this is the hypoechoic tract going across sphincter, and then this enters the ischial space, resulting in this hypoechoic collection of pus. So this is a ischial. In the upper part of the anal canal, you can see the hypoechoic tract cutting across the superficial external sphincter and probably contacting the internal sphincter at about 7 o'clock. Everything looks good. This is the pubis rectalis in the upper anal canal. You can see the intersphincteric space is very clean. Now, from the intersphincteric space, I mentioned that the infection can track in all directions, and in this patient, the abscess would track around the anal canal. You can see this is the lower part of the rectum. This is the anal canal, and there's this coronal view shows this collection of pus on the right and on the left. This is the axial view. You can see this collection of pus encircling the whole anal canal. Okay, so this is a circumferential extension of abscess. In another patient, you can see this is a upper anal canal with the pupil rectalis. You can see a large abscess posteriorly with extensions on either side. So this is like a horseshoe extension. In the coronal view, you can see the internal sphincter nicely shown on the left. This is the subcutaneous portion of the external sphincter. This will be the ischial space. You can see there is a left ischial abscess going up to the infralevator portion on the left. This will be the levator plate with the pupil rectalis around here. So this horizontal area will correspond to this cut where you will see a horseshoe extension at the level of the pupil rectalis. And there is also a horseshoe extension in the supralevator space. So the infection tracks along the intersphincteric space high up posteriorly, and then you have a supralevator horseshoe extension as well. So of course, in this patient where the infection is tracking everywhere, we elected to treat it with small stab incisions and seton place in the left ischial space coming out through the internal opening posteriorly, and as well as a incision at 6 o'clock going into the deep postanal abscess, and then we drain this again through the internal opening posteriorly at 6 o'clock. Now, how does ultrasound compare with the physical exam? Obviously, for simple tracts that are easily palpable with the lubricated finger on the perianal skin, the physical exam compares well with the ultrasound. But when we will start having deep extensions of the tract or of the abscess, like horseshoe extensions, then ultrasound is superior to physical exam with 85% accuracy on ultrasound and only 58% on physical exam. Ultrasound is also superior in localizing the position of the internal opening at 85% versus 69% for physical exam. And of course, these values are statistically significant. But what about MRI? Well, you can see on both sides, ultrasound gives you excellent correlation or accuracy when compared to the MRI. Of course, the only thing is that the focal length of the ultrasound probe is only about 2.5 centimeters. So it does only give you a small field of view. For infections or tracts that track hard into the supralevator space or into the pelvis, then of course the MRI will be superior to the ultrasound because this will be beyond the field of view. But other than that, in terms of evaluating the nature of the primary, secondary tracts and abscesses, ultrasound compares well with the MRI. And of course, it's much more comfortable. It's a quick exam with a 3D probe, less expensive, and of course, easy access because you can place the equipment in your clinic next to the patient examination couch. However, in both modalities, there is a learning curve, but it can be easily learned by the surgeon. So in summary, endoanal ultrasound allows for accurate preoperative imaging of the anal abscesses and fistulas. It gives you good correlation with operative findings. It enables the operator to assess anal sphincter integrity, especially in patients who have had multiple surgeries. Hydrogen peroxide is a very useful contrast agent and helps us differentiate fistula from scar tissue. And of course, in the era of the lift procedure, where we make small incisions to assess the tract in the intersphincteric space, ultrasound is very useful for locating this portion of the tract, hence help us site incisions for the lift procedure. I will now move on to my next lecture on how to do an endorectal advancement flap. The fundamental principle underlying this procedure is to create and advance a flap of rectal mucosa or a bit of the wall distally to cover the internal opening. In doing so, it brings well vascularized tissue to the surgical field, consequently a higher chance of healing. This should be considered in a situation where the patient has had multiple failed previous surgeries. Although there is minimal sphincter division, it is not immune to the risk of altered continence. The results of a flap is as shown over the years in multiple large series. The most recent one published in 2017 with 65 patients. You can see that the primary healing rate of the fistula averages between 75 to about 80% with a mean follow-up of at least 2 years. As you can see in all these papers, they are not without incontinence. In this study, comparing full thickness and mucosal thick rectal flaps in the treatment of high cryptoglandular anal fistulas, they documented a significant incontinence in 11.1% of patients. There is an improvement in the success rates of full thickness flaps without any higher risk of incontinence for when compared to partial thickness flaps. However, in this larger systemic review or meta-analysis of 26 studies with 1,600 over patients, you can see that as the flap thickness increases, the success rate in that the recurrence rate will be lower, but there is an increased risk in incontinence. So what are the causes of flap failures? As I mentioned earlier, it's not foolproof. It's successful on the average about 80%. Well, for one, there may be an overlooked secondary sepsis or tract, or there may be insufficient drainage of the infection, or there may be poor blood flow to the area combined with tension when we suture down the flap. And of course, we must always rule out unusual pathology, such as TB or Crohn's disease. Now, this is a 46-year-old lady whom I had shown earlier in my previous lecture, present with a history of a horseshoe anal abscess that was aspirated whilst she was living in India. Obviously, it recurred a year and a half later, And again, they went for a CT-guided aspiration drainage. And then she did an endoanal ultrasound. Post-aspiration of the abscess was still very much present. In fact, it became more complicated with supralevator and infralevator, horseshoe, as well as a left ischial extension. Now, this is the horseshoe infralevator collection. In the coronal view, you see a supralevator collection, infra as well as the left ischial extension. This is the sagittal view with the deep anal abscess collection. And in the posterior view, you can see the horseshoe extension in the infralevator space. So we drained this abscess and its extensions with cetons. We left it there for 2 months. Repeat ultrasound imaging showed that most of the abscess has been well drained with peroxide enhancement through the external opening at where the ceton goes in. You can see these are the cetons with the nice tracks with the extensions. There's no more pus collection. And so then proceeded to treat this complex fistula, having drained successfully the sepsis with the endorectal advancement flap. So this is the flap that's been harvested. We trim off the distal edge and we down. And I will show you a video as to how I would do it. So we first place a Lone Star retractor to efface the anus, and then we infiltrate the site of planned incision with adrenaline 1 in 100,000 solution. And then using a 15 blade, we will make a U-shaped incision. So the flap is more broad proximally. The distal lip encompasses the internal opening. And then we use scissors to dissect. So this is a full thickness flap, and we make sure we mobilize the flap distally so that it is without tension. The external tract is curetted. We flush it with hydrogen peroxide. And one of the main components of this procedure is to suture close the internal opening in the muscle with a 2O polysorb suture. And I use this with the UR6 needle because it does give you a very big bite. And in many cases, you can even obliterate the post-anal space. I also imbricate the muscle. Remember, this is a full thickness flap. So I close the muscle to cover the primary internal opening closure. And now I pull the flap down and I suture it first distally and hold it in place. And then I close the lateral aspect of the flap. Again, making very big bites to include the muscle as well as the mucosa. This is the left side of the flap. I do not use any cautery for this procedure. You can see the adrenaline solution does make it a very nice and dry feel. Using the suturing of the flap would easily secure any bleeding. So the distal edge is then knotted down. So the enemy of good is perfection. So just enough sutures, not too tight. You don't want to strangulate supply. I should put a spongostan for added hemostasis. You can see the external opening over here, and the Lone Star is removed. So what are the learning points? Well, the flap has to be broad base proximally, full thickness. I use adrenaline infiltration, sharp dissection, minimal or zero cautery. I need to suture close the internal opening defect at the flap donor site and taking deep bites to obliterate any dead space. I use 2O Polysop or 2O Vicryl sutures with a UR6 needle to anchor the flap. Now, post-operatively, I place the patient on a liquid diet for 1 week. This is almost like a medical colostomy. I don't want the patient to stool too much or too fast. There is no need for stool softeners like lactulose because diarrhea can also stress the flap suture lines. I don't allow spa because that will make them squat and that will place unnecessary tension on my flaps. I ask them to use a shower head to spray the wound clean if they are to go to the toilet. And of course, I give antibiotics, usually if without penicillin, augmentin for 1 week. And as mentioned, avoid prolonged sitting or squatting. They can lie down or they can walk about the house. And I usually review them early in 2 weeks. In summary, endorectal advancement flaps is a good sphincter preserving option for complex anal fistulas. It has on average a success rate of about 80%. It does, however, carry a risk of incontinence in about 11%. The risk of failure is lower, but risk of incontinence is higher with full thickness flaps when compared with only mucosal thick flaps. In patients who have previous failed surgeries, the endorectal advancement flap does bring well vascularized tissue in the surgical field, and it remains a very good option. Thank you very much.
Thank you, sir.
Wonderful presentation.
Thank you, sir. Thank you, sir, for your enlightening presentation, sir. It was actually indeed a pleasure to us, sir. Sir, again, we will talk with you in interactive question and answer session, sir. Now, our last speaker, we are feeling honored to Parvesh Sheikh, sir, for your speech regarding fistulectomy with primary sphincter reconstruction in the management of complex fistula in ano. Sir, Parvesh, sir.
Thank you, Dr. Arun, and assalamu alaikum to everybody.
Sir, I think your network is interrupted, sir. Parvesh, sir, are you hearing, sir?
Excuse me, I think you can contact the RAS TV. There is a problem. Can you hear me? If there is a problem, you can contact RAS TV to improve this.
Problem বোধহয় ওখানেই তার
RAS TV, please.
Abjal,
this happens. This happens.
ঠিক আছে স্যার। স্যার, আমার মনে হয় স্যার এটা স্যারের ওখানে কি
It
নেটওয়ার্কের কোনো
possibly স্যারের এটাই হওয়ার কথা।
So somebody should check it. Somebody should check it whether there. Okay, that's fine. Thank you.
স্যার, ওকে স্যার, আমরা দেখছি স্যার। পারভেজ স্যার।
অরুণ বিসি স্যার আসছে কিন্তু।
হ্যাঁ। পারভেজ স্যার, are you hearing, sir?
Call Parvez with a phone. Call Parvez with a phone, please.
Sir, please, sir. দেখছি স্যার আমরা স্যার।
ওকে অরুণ, আমি কল করছিলাম, বলছে যে জাস্ট লগিং কানেকশন হয়েছে, আমি আবার কানেক্ট করছি।
স্যার তাই মনে হচ্ছে স্যার, নেটওয়ার্ক তখন তো স্যার খুব স্মুথলি ছিলেন স্যার আমাদের সাথে।
না, he is reconnecting because he's net disturbing. Just I called him.
Sorry for little interruption. Hopefully, sir will connect within 1 or 2 minutes.
Yes. He's here.
Sir. Parvez sir, please unmute, sir. Audio.
Hello, can you hear me now?
Yes, sir. Sir.
Okay.
You are hearing, sir.
I'm sorry for that. My connection just went off. So I'll just start my.
Yes, sir. You can start, sir.
The high transient fistulas. So, procedures, and well, they have a role to play and they are good enough. But what I want to say is that among all the sphincter saving procedure, I think lift is a very good procedure. And I would personally recommend lift for among all these sphincter saving procedure with a high success rate. Charles has talked about the advancement flap, which is also a good procedure, but I personally prefer lift as a sphincter saving procedure. But when it comes to the sphincter cutting, you have, of course, fistulotomy, fistulectomy. You also have a cutting sit-on, which is, I think, not very popular and can have more complications. If you're just doing a fistulotomy or fistulectomy, especially in a high fistula, your incontinence can be quite significant. The success rates are high, very high, and I think no other procedures give high success. Incontinence can be a problem. So it is better if you were to suture the sphincters if you were to cut it. I'll just give you a couple of examples. This is a York Mason procedure for a rectourinary fistula, where the approach is from behind, where you would cut the posterior sphincters, anal sphincters posteriorly, approach the rectourethral fistula and rectourinary fistula, repair it, and then suture the muscle back. And they found out that after this repair, there's really no fecal incontinence or disruption of the rectal function, in spite of cutting the muscle, So in females, anteriorly, we are worried about especially anterior fistulas in female patients. It's considered to be complex because of the high risk of incontinence. But when all of us who repair perineal injuries or obstetric injuries, third degree, fourth degree tear, when we repair them, of course, the muscle cut here is much more than we would otherwise cut for a fistula surgery. But if you repair these primarily on the day of the injury, you have full restoration of the anal pressures, voluntary and involuntary control, and almost complete anatomical recovery of the anal flex. Of course, I'm not suggesting that everybody should do that, but you can do it. Probably if you have the right experience, you know how the fistula is going, whether it's high, low, and depending on that, you would place a judgment whether to do this or not. But one can do it. I do it certainly. So if you're doing a low fistulotomy, of course, we don't need to suture the below the dentate line, the only superficial and subcutaneous part basically. But if you're cutting there where the high transsphincteric fissura passes, that is between the deep and the superficial part of the external sphincters, I would certainly recommend suturing this because you may not have a gross incontinence because it is still below the anorectal ring, but you can have some degree of incontinence, very minor incontinence. I'll just quickly show a short video to represent just to show you what I do. I always go just to identify the tract, identify the internal opening, and I will just run this video a little fast. So I do when I don't do a fistulotomy, I do a fistulectomy. So here is where I'm coring out the tract. So I core out the tract. The advantage about coring out a tract is that you can make out if there are any abscesses, any extensions, any branches, everything is seen under vision. Now you can see this, both these tracts, they are basically interconnected subcutaneously and they are entering the external sphincter. Single tract is entering the external sphincter. If you give a tug, you know where the internal opening is, if you have not already identified earlier. I take an incision around the internal opening, and maybe you can just take it across the internal opening also. But I'm taking it around to excise the internal opening and go deep to excise the remaining part of the tract. Now here, this is what I'm doing. It's the cutting the sphincters. Now there's a deep part, the superficial part, and the subcutaneous part of the external sphincter. This is where I am cutting. That is, what I'm cutting is the superficial part, subcutaneous part, and the corresponding part of the internal sphincter. So this is where, and still I'm below the anorectal drain. What I'm doing. So this is, I'm completing the dissection by excising tract. And you can see that there's a specimen, the tract is excised. There's a deep part of the external sphincter, which is still very much there. That is, I would not recommend dividing that. That's the corresponding part of the internal sphincter. So now once you make sure that your entire disease is out, you just approximate, I just approximate the sphincters with a PDS suture. This is a 2.0 or a 3.0 PDS you could use. And that is good enough for the muscle. I take interrupted sutures. I usually try to bury the knots. The mucosa, of course, I suture with 3.0 Vicryl. It's a good idea to take a bite of the internal sphincter along with the mucosa so that the chances of breakdown are less. And just keep on suturing it alternately, the muscle and the mucosa. And this gives fairly good, but a good cosmetic result also, because you don't have a lot of deformities there. Now, what about bilateral fistulas? I'm going to show you a video about this. You can see this fistula, this particular fistula. It is a bilateral transsphincteric fistula with a horseshoe intersphincteric extension. So what I'm going to do is I'm going to start on this side, excise this tract by dividing the sphincter, do a fistulectomy here, divide the lower part of the sphincters, then core out this whole tract in the intersphincteric space. If it is a bilateral tract, I cut the muscle only on one side. I don't cut it on both sides. So the muscle here, this part of the tract, I will just core out up till here. And then this part, I will core out through the sphincter without actually cutting the sphincter. So if you just have a very thin tract, you can just core out this part, the part which passes through the external sphincter, or you can just core out from there. And anyway, this I will be suturing back. So I'm going to cut the muscle on this side and not cut the muscle on this side. So we will see a video. Now, this particular lady was operated 4 times to me. You can see various procedures were done, and the last time a seton was passed. You can see that the opening is in the posterior midline, and one seton here and another seton here. So what I'm going to do is I'm going to start my patient. I do my surgeries under local anesthesia. Similar, this is under local anesthesia with a sedation. So methylene blue is injected. Of course, this got a seton, so the dye has come promptly. So I'm taking a vision around one of the external openings and just coring from there. So again, I said I usually do a coring out. I use an electrocautery actually. Skin tag which I'm excising. I try to give a good cosmetic result. So if there are any skin tags and things like that, I try to excise them. Now you can see that I'm cutting the sphincter and just following the tract. I've just recorded this about a couple of weeks back, actually. Last month, I think I've recorded this. So this is a little poor editing from my part, but all the same, you can see this is the tug which identifies the internal opening, but of course we already knew where the internal opening was. So I'm just following the track, coring out. Very simple, just follow the fibrosis. And you can see the muscle the sphincter being divided. You can see that is the internal opening. Okay. So laying it open and continuing with the dissection, basically. So keep very close to the track. You should not exercise a lot of muscle. Just keep very close to the track. So now going on the other side and dissecting on the track on the other side. As I said, I will not be cutting the muscle here. I will just be coring it out through the muscle, basically. And that is a track being cored out. So it's a very simple procedure as such. There's nothing much. I think we all do coring out techniques. Now I'm going in the intersphincteric space, okay, between the internal, the external sphincters. So the internal sphincter is now up in the superiorly. I'm going between that space, and I'm going to be sort of coring out the intersphincteric portion of the tract. The horseshoe intersphincteric portion of the tract is what I'm dissecting now. This way, I'm going to be excising the entire pathology, and that's why the recurrence rates are less. You can see that that is the right arm of the horseshoe, which I am now dissecting. That is the intersphincteric dissection again. And you can see I use electrocautery, so the field of vision is comparatively clean. You can see that methylene blue now, there is a cavity there actually. So I'm going to be, that's an intersphincteric, in the intersphincteric space. So I'm going to be excising that cavity also. So I normally excise everything. And since we are not actually, at this stage, we are not actually cutting the muscle. We are just going between the two sphincters. You can see the white cavity now, the blue colored white cavity, which is there. And you can see that I'm going to the on right side, at the left side of the patient rather. I'm dissecting out the left limb of the horseshoe tract and also part of the transsphincteric. The transsphincteric portion you can see that. So now in this, at this point, I will not cut the muscle. As I said, I'm only out through the muscle. So that part is removed. Now I'm just completing the dissection and removing the part of the remaining part of the tract. So you can see the entire pathology is out. That's the mucosa, that is the internal, the external sphincter, the deep part which I have not cut, and that is the horseshoe intersphincteric space. So the entire pathology is out. There's nothing remaining behind now. And that is the transsphincteric space from where the tract was excised. Now I'm using this PDS. First thing is I'm using this intersphincteric space, and at the same time trying to tighten the sphincters also. As you can see, the external sphincter is very much visible, which is intact, the deep part is intact. So this is closing the intersphincteric space, taking both the internal and external sphincters on either side. And suturing this. And of course, you take mucosa with vicryl, suture with 3 vicryl, the mucosa is taken, and so on. You just sutured it. The advantage of this procedure is it is a bit radical procedure, but it definitely removes the entire pathology. And if you suture the sphincters, you get good continence also. There could be a problem with disruption of the sutures. Mucosa sutures can disrupt, but that doesn't affect the outcome, so long as the muscle is intact. So this is just suturing the, you can see the, now this is the sphincters, the external sphincter, whatever was cut, I'm just suturing it back. And you can see this is the last bit of the surgery. And this I'm doing under local anesthesia. So I do it as a daycare procedure. The patient comes in the morning and She was from another city, so she went back to her hometown in the night. So you can see that. So now if you see at the end, this I've sutured this back, this just made it flat, and you can see there's hardly any wound there. So even the dressing and all is very little. Of course, I inject methylene blue. One of the problems about sphincter repair is the pain. So I inject methylene blue into the mucosa and into the sphincter to decrease to have, so the patient has less post-operative pain. You can see this is the end of the surgery. This is how a very superficial and a small line. This I have sort of marsupialized this. So close the hole in the external sphincter and marsupialize this so it's become flat. We have done a primary surgery, removed all the pathology, and at the same time, we have kept the patient continent and given her a fairly good cosmetic result. So this systemic review, which was published by the Italian group of Rectal in 2015 regarding this procedure, they said that the success rate was 93%. The overall post-operative worsening continence was 12%, but it was mainly post-defecation soiling rather than incontinence. And more important, in almost all cases, the anal manometry parameters remain unchanged. And the gold standard quality of life, which we all consider it as the eventual parameter, the quality of life improves significantly. And thus, it is a good procedure for complex anal fistula. Success rates are high, and the risk of fecal incontinence was much lower. You can, of course, give good cosmetic results even if you do this radical procedure. You can see this patient where I have done a coring out technique. This was going parallel to the urethra periurethral extension. I've excised this whole thing. And after fistulectomy, there's a very small wound which is left behind. So even you can give good cosmetic results following this. So ultimately, to end this, fistulectomy with primary sphincter reconstruction is useful, especially for high transsphincteric fistulas. With high interstitial extensions, you can tackle both together. We would never recommend dividing the anorectal ring. So always keep below the anorectal ring. Success rate is more than 90%. In my personal series, I have almost 98% success rate with no significant incontinence. You have a problem of post-operative pain because you're cutting and suturing the sphincters. But as I said, I inject methylene blue, and that takes care of the pain in the first 3 or 4 days. So thank you for this, and I'll stop sharing.
Thank you, sir. Thank you, sir. We are grateful to you for such an academic session. And again, I seek my honor to all the distinguished speakers to making this session too charming and academic.
Let's move toward the next part, the panel of experts session. First of all, I would like to invite Professor Mohammad Shahadat Hussain, sir. So what do you think? And would you please share your experience regarding this topic?
Please unmute, sir. Sir, please unmute, sir. Oh.
It's all right now?
All right, sir.
Yes,
all
sir.
right, sir.
Respected Chair, Professor Mutiur Rahman Sir, Professor Kanak Kanti Borua, and the expert panelists, participants, and the 3 distinguished speakers. All these 3 papers were so interesting and wonderful, really. I think I myself become very much benefited with coming here, as well as I think all the participants will be benefited with the techniques. Particularly, I want to give emphasis on Dr. Rosana Sakul. I have attended his lectures before. I think always there is the chance of development and further advancement. And some new thing I think I may have missed in previous lectures also, but the new thing that I have noticed, particularly the marsupializations of the intra-anal fissurotomy. And he has also showed some of the abscess cases, even in the abscess, acute abscess cases, he has done the lift procedure. That is also, and I think, a new development for me. I think that we may have done it long before and we have demonstrated in different parts of the world, but I think that I have learned it new. I think all the participants will be benefited by looking into it. And another thing that in previous lectures I have not seen him to put any drainage, tube drainage. Is it new thing? I want to learn from Brother Sakul that whether it's a new development he has added to his procedures. Because previously I have not seen the tube drainage. And I want to know that how long he keeps that drainage after operation. Regarding Charles Sang, that is also very interesting. You know that this is also the intra-anal advancement flap, which is not built in our country. I particularly am not very much accustomed to this. I think that also is very helpful, and all the new surgeons of our country will be benefited by applications of this procedure in their cases. And regarding Dr. Sheikh, Parvez Sheikh, I had the opportunity to attend his lectures before also, and it is really very interesting that he is saying, even by doing the division of the sphincters, there is no impairment of the continence. It is wonderful. It is wonderful. And the principle he has taken from the complete perineal tear, that is also very interesting. They also causes some interest in our mind also, if it is possible in the studies, why it is not possible for surgeons. So that is a very good applications of the observation from the other, I think, the other specialties. One thing I want to know from Parvez say that whenever we cut the muscle, particularly the skeletal muscle, the skeletal anywhere, there is chance of going apart. It contracts and the gap becomes more. Is there any difficulty in case of the repair of this sphincters? I want to listen it from Dr. Parvez. Thank you very much. Thank you, everybody.
Thank you, sir.
Actually, we are talking about primary repair of the sphincters. We are not talking about delayed repair. When it moves away, it is for a delayed repair. If you just cut it and you leave it, then the sphincters might move away. But if you're suturing it primarily on the table itself, the muscles are right there. They don't move away in a few minutes or half an hour or so. They are very much there. It's only when you're doing a delayed repair after 6 weeks or 12 weeks or something like that, then they would. So it's very simple. One tip I would like to say is that if you want to suture, if somebody new is doing it and you don't know how to suture or where to suture, what you could do, you could take stage sutures before dividing. So you take one with black, one with maybe linen suture, one with black silk, so different colors. So when you cut and when you have to suture, you know which end will go where, and you could just, I just take simple approximating sutures, and there's no double breasting or mattress or something, just simple, because the blood supply has to be maintained. We don't want to make it very tight. Also, you need to know your anatomy well before you know how much to divide. So you always keep on feeling the inner rectal ring. Your inner rectal ring should be intact. And if you're talking about a high transsphincteric, it is below the inner rectal ring. It is not above the inner rectal ring. So if you're in the right plane, actually, there is no problem. I think Arun had you had asked question to Arun about how long he keeps a drain. And even I wanted to ask Arun this, that I have never seen you putting a drain earlier from the external wound. As I understand, Arun, you put a drain from the external opening till the intersphincteric space, right? Through the external sphincter. Because earlier you were saying that we should securely close the hole in the external sphincter from where the tract is coming out. But now I saw that you have put in a drain through that. So why have you changed your approach? And as Professor asked, how long do you keep the drain?
Arun sir, please unmute, sir. Please unmute, sir. Sir, please unmute first, sir. Sir, we can't hear, sir. Sir, please unmute, sir. Yes.
Arun sir, please.
Yes, but wait 1 minute.
Now we can hear, sir. Now we can hear it, sir.
You can ask other question to Chow, and then I come back later. Okay. 1 minute, 1 minute. I
No,
try to.
Arun, we can hear you, Arun, now. You can.
Yes, yeah. I
Sir.
show you the picture. I show you the picture.
Sir, Charles sir, you can put your comment first, sir. Then Arun sir will put.
I will give my comment now. Okay, can you see? Hello?
Yes,
Can
sir.
you,
Yes, sir. We are seeing, sir.
You have seen the drain, the tube drain in there. The one cause of recurrent leaf is infection in the cavity or the tract, in the distal cavity of the tract. How to manage the infection here, you can lay open here, you can call out, or you can put a tube drain after curate. And you can remove the tube drain at 2 or 3 weeks if there are no discharge. After that, you follow up 1 week and it heals. Or if there are some infection, reinsertion of tube drain. And if persistent of discharge, long-term drain or reoperation. Reinsertion, if drain disappear, no discharge, remove it. Okay, like this. You understand now?
Thank you. Thank you very much.
Nowadays, I use silicone drain more often. And sometimes I put a small silicone drain, maybe 2 tubes. At 2 weeks, I remove 1 tube.
Thank you, sir. Now let me invite Professor Shahadat Hossain Sheikh. Sir, would you please add few words regarding this session?
Thank you. Thank you very much. Respected Chairperson Mutira and the Chief Guest, Professor Conor Kantra, Honorable VC Sir. So actually 3 different type of presentation on complex fistula in nano, and all the lectures are, it's a very amazing presentation of all the speakers, and congratulations to all the speakers. And a few, actually I have no comment, but a few query to every speaker, like Professor Arun. I'm just wondering, when you don't find an internal opening, so we are doing some fistula surgery by the technique of the core out lift. But what is your opinion about when you don't really find the internal opening, then what you do?
If I cannot identify the internal opening, I will do the coring out.
Okay.
And most how it will direct to the intersphincteric plane. If it's when coring out and come near the anus, then I make the lift operation in that area, and we can see the tract. But very, very few cases, when we coring out, it disappear. Very few cases. It means that it can be a hydradenitis, not the fistula, because it already disappeared.
Okay. And how you deal in your personal cases, like the patient having the Crohn's fistula? What you do really?
The Crohn?
Yeah.
The Crohn fistula? Oh, very, very rare. Very rare. Normally, first consultation with the GI man first.
Okay. Okay.
And drain. If it's a severe proctitis, I would prefer drain, like a season drainage. But
okay.
Very rare Crohn's disease in Thailand. Very, very rare. But I do have some patients from the Middle East. So that's what I did.
Okay, and Professor Charles, and I'm just thinking about why you take usually full thickness flap for the end advancement flap, right? Or
yes.
Sometimes you take the partial thickness.
I usually do quite a full thickness, yes.
And you showed the incontinence is higher in the full thickness. So why you don't take partial thickness? You think about the vascularity or something else?
Vascularity is one, and also the thickness of the flap would give you a bigger bite when you suture the flap down. So there's, and also the chances of success of a thicker flap is higher, albeit the risk of incontinence is higher. So that's why after I harvest the flap, I would also imbricate the muscle. So it's not very different from what Ave would do when he does a FIPS. Means after he lay, he will repair the muscle. So when I take a little bit of the internal sphincter as part of my flap, I would repair the internal sphincter as well over the internal opening closure. So you kind of tighten it, and then I bring the flap down. So the thickness of the flap does matter, I think. Yeah.
And do you ever use the ICG to see the vascularity of the flap?
No, I don't. I have not used it. Yeah. Yes.
Okay.
Yeah.
Okay.
I
Okay,
think
Charles.
the flaps are not very big, but it's broader proximally, and then you should have.
So there should not be any problem with the vascularity.
Yes. Yeah. And no tension. Yeah.
Thank you very much. And Professor Parvesh Sheikh, actually, I don't have any question because what I wanted to ask you by this time answered about your incontinence rate in your personal series. So that's very minimum, right?
So I tell all my patients beforehand, I cannot guarantee you incontinence to flatus or continence to flatus. So almost I would say 30% of my patients lose continence to flatus. I've not had any patient with frank incontinence to stools, but incontinence to flatus. But I also asked them the question. I said, do you remember the last time that you needed to control your flatus? Any situation arose where you need to control your flatus? And most of us, even if we have to ask ourselves, most of us can't remember the need we had to control our flatus. So 38% of my patients do lose control of our flatus, out of which half of them recover. But every time, like I did a survey, and after 3 months, I asked all my patients, and they had to think whether they had flatus incontinence or not, because they could not remember, that because when you want to pass flatus, we just pass it. So normally we don't control it. That's the issue. I've had few occasional fecal urgencies, but they with little physiotherapy and all, they all recovered. So I don't have any patient who is incontinent to stools, or needs to use a pamper or is hampering his quality of life. No, I don't have any patient like that.
Okay, that's great. Great. So thank you. And once again, congratulations to all the three speakers. Thank you very much.
Thank you.
Thank you, sir. Thank you for your informative observations. Lastly, I would like to request Professor Muhammad Abu Tahir sir to share his views regarding this topic. Sir.
You can hear me?
Yes, sir.
Respected chairperson, Professor Dr. Motur Rahman sir, who is chairing of this webinar, and our honorable chief guest, Professor Dr. Konakante Borwa sir, Vice Chancellor, Bangaldesh Sheikh Mujib Medical University, and our guardian. He is always with us in all scientific seminar. And another special guest, Professor ABM Khurshid Alam sir, Director General of Health Services, and three distinguished speakers, Dr. Urun Rajana Sakul, Dr. Charles Bishayu, and Dr. Parvesh Sheikh. These three speakers, they nicely presented their cases and demonstrated their cases. Thanks to all the speakers and distinguished panel experts and my dear moderators and other teachers and doctors, my respected teachers and doctors who are participating in this webinar, my salam to all. Actually, today's webinar on art of management of fistula, complex fistula. Complex fistula, usually we know that name indicating the complex, that means always this part of operation is challenging throughout the world for the colorectal surgeons. Among these, Dr. Rajana Sakul invented a door for complex fistula. That means he invented lift procedure in 2007. After this, many complex procedures were doing by lift procedure, and he nicely demonstrated today. And the two speakers, Dr. Charles showed nicely, and Dr. Advancement Plan how we are doing this procedure. Always we think how we'll get successfully we can do fistula operations. Always we remember that what is causing the failure? When there is unexpected secondary tracts, the length of the tract or the fistula, lateral localization, internal opening, and other comorbid condition like diabetes, smoking, obesity, all are should keep in mind when we are doing any kind of fistula operations. My in many literature showed that when there is inflammation or active sepsis, in that time they are using drainage procedure in before going lift. My question to Dr. Rojana Sakul, Dr. Orun, you are never using a drainage procedure. If you use drain, how long you are using this drain procedure before going lift? Dr. Orun.
I already show you how I put the drain and how long I keep it. Is that the questions?
No, Arun, he was asking you, if you drain the abscess, how long do you wait and do the lift procedure?
Oh, my answer, hello? Can you hear me?
Yes.
My answer is that I always do the lift during acute abscess. So any case of abscess or fistula come to me at any time, I will do the lift. So just simple as that. All case. One operation for all case. No sedent, no drain, just lift.
Okay, fine.
Even chronic.
Okay, Doctor, my another simple question to Dr. Parvesh Sheikh. You nicely showed your sphincter reconstruction, but we saw that you did it direct closure of the sphincters. But here, there is any option of overlapping procedures, and if you do, which is which procedure you choose, direct closure or overlap repair?
So I do a direct simple closure. You saw that direct approximation. Overlapping I would do if it's a delayed repair, say an obstetric injury, which I'm doing electively after 3 months or later on that, then I would do an overlapping. If you're doing a primary repair at the same time when you're doing the fistulectomy, when you're cutting the sphincter, then you don't need to do a overlapping, because for overlapping you need to mobilize, and it is not necessary. Now when we do an abdominal incision, when we open the abdomen, we're just approximating, right? There is more stress and more tension in the abdominal muscles rather than in the rectal muscles. But we are just approximating. We're not double breasting. We're not doing anything. The same principle applies there. We just approximated. It's not a delayed. If you're doing a delayed repair, maybe you may need to do an overlapping. There is no clear mandate whether you should do overlapping or not, even in delayed repair. But for primary, I think repair, it is very easy to do a direct approximation, and that works.
Okay, thank you. Thank you to all. With this small things, I'm concluding my speech. Thank you to all.
Thank you, sir. Thanks for your beautiful remarks.
Again, thanks to all the speakers. Now it's a interactive question and answer session. Only one question till now came, that what is the role of endorectal advancement flap for treating Crohn's disease in fistula?
Excuse me.
And it is already answered in the already answered by Charles, that I am ultra conservative when it comes to Crohn's. Just set on drainage and that treat the Crohn's disease. Orun sir also commented that Crohn's is very rare in their country. Now, to my question to Parvesh sir, what is your experience in Crohn's in India, and what treatment you prefer and fistula in Crohn's disease?
So Crohn's, 20 years back, we didn't have much of Crohn's, but now we are seeing quite a lot of Crohn's. The incidence is going up now. In Crohn's, of course, I think I would recommend a conservative treatment. So if there is an abscess, I would drain it. I would curate out all the tracks, and I pass a sit-on and I keep. And basically, as Arun said, I work with a medical gastroenterologist. So biologicals is what is going to be helping me. So once you remove the sepsis, you pass in a sit-on. The patient has started on infliximab or whatever biologicals that. So at least after 2 or 3 courses, then I would remove the sit-on, and usually it heals up.
Can I ask a direct question? Is it possible? Is it
Absolutely.
possible?
Yes, sir, please. Continue,
Okay.
sir.
Okay, please. Thank you very much for giving me opportunity. I'm from Chittagong. We are practicing colorectal surgery for more than 20 years. My sir is here, Moti Rahman sir, and Professor Shahadat, two Shahadat sir here.
Thank you.
And also welcome. And also Sang, I had a good friend too in Singapore, Sim at that time, Mr. Sim, who was the president of Colorectal Surgeon Society Singapore. And your pioneer, Gohaksu, he was also my friend at that time. So all of them I know. One thing I am following exactly what Parvesh Sheikh is doing for long 20 years. And one specialty of the muscle of anal region, this is a sphincter. And it remains closed for a long period all the time, only open for a short period. So I just remembering that. So there is no chance of going apart when you are going for a suture. And we are doing it, repairing it for a long period. And over, this is only we are doing in case of females. And if there is any episiotomy, there is only chance of the internal sphincter overlapping the suture, but not for the external sphincter and others. Okay. And I have one, not only question, I have one suggestion to Arun. Any lecture in your later, we want long period, we are doing coring out, repair, what actually Parvez has so almost all these we are doing. I told him earlier also, what is the difference? Because Mato has done in 1993, this what have you done today as a lift, and you have modified this lift. So one question remains, what is the basic difference you suggest is later on this lecture? What is the basic difference between coring out and you lift? Is it a simple suture? Is it a approach through the intersphincter space, or it is an opportunity to close? What are these? And if say a postgraduate student is coming with a master's in colorectal surgery, if this is a question, what is the difference between the coring out and Parvez method, and what is the difference with the lift in case of Arun? I don't want to hear it now. I think you can do it because you're doing it now, even in a more advanced year. I would not be actually courageous enough to do your lift in case of acute cases having an abscess, because it is very difficult to find out where it is. So, and the other thing about SAG, we are preferring, though we have not enough logistics, we have got our own MRI set up to try to take the pelvic MRI and anal. Initially, we tried with the anal coil, but we failed. Our people are not accustomed to doing it. Even now, we are doing it, but we are not having good result. I think the simple one is with them. And this anal ultrasound is in our country also, we know. I don't want to mention. So thank you very much, my dear sir and other friends and coming the guests, and Parvez and Sang, and also my sir, Professor Moses sir, and all of you. Thank you very much for giving me some opportunity to talk about it. Thank you very much.
Thank you. Thank you.
Many of senior teachers are with us. Professor M.A. Mojid sir is a very senior teacher and teacher of our teachers. Sir M.A. Mojid sir, please, would you like to comment something about these presentations, or any suggestions or tips? And
thank you very much for asking me to make a comment. All that I can say that all this presentation by three distinguished speakers were very interesting, very informative. Only thing I want to make a comment about the Crohn's fistula. This is my experience with Crohn's fistula, that in fact the Crohn's fistula I dealt with had some other fistula, that is intestinal fistula, for example, following appendicectomy. And it was done outside this country. And I found that if we treated this patient with Crohn's disease with the conventional drug like sulfasalazine and other drugs, even I'll not go for drugs like azathioprine. Sulfasalazine is good enough in this sort of situation. This small fistula, in fact, if you can control the systemic disease, this fistula themselves closes spontaneously. This is my experience. This is the only comment I wanted to make. Thank you very much. I once again thank all the speakers for their very wonderful presentation. Thank you.
Thank you, sir, for your nice comment. Thank you, sir. Another very simple investigation is doing in our country by different surgeons are fistulogram, especially in periphery. The endorectal ultrasound and MRI is not available. So my question to the presenters and also to the experts, panel of experts, about the role of fistulogram in complex fistula in ano. It's a open question. Sir.
I would like to say that actually even that same problem in India also people ask me when I go for lecture, especially from rural areas, they ask whether there is only investigation available. But really fistulogram doesn't give us any information about the type of fistula, how the fistula is. If the internal opening is blocked, you may not see the dye inside the rectum. So, it doesn't give the information that we need to decide about the line of treatment. So it's no longer recommended actually. Fistulogram is no longer recommended. That said, the only times that I would use or do a fistulogram is suppose I have an opening in the thigh. This is a bedside thing. I want to know whether it is communicating the rectum. So in the clinic itself, we just put some saline and hydrogen peroxide and see whether it is coming in the anus, then you know. Or you have operated a fistula and the wound is not healing. So, it's 2 months, 3 months, there's still some hole. You want to know, of course, you can do an MRI, which will tell you whether fistula is there or not. But as a bedside manner, you can just put in a saline hydrogen peroxide. And if it comes in the anal canal, you know that there is a fistula and patient would need surgery. So, but as a fistulogram as a investigation tool is no longer recommended, especially today in the era of medical legal negligence, medical negligence. Patients, we are trying to say that patient to tell the patient that okay, we don't have the facility here, so we do not recommend, but at least you should write it on the paper that recommended MRI. If the patient does it, not does it is a different problem, because this same patient can turn around and say, you did not advise me MRI. I would have done the MRI from wherever I would have possible. So I think it is important that you should, if you think MRI is necessary, you should mention it. If the patient doesn't do because of lack of facility is a different thing. But the bottom line is fistulogram really has no role today.
Yes, I would agree with Parvez Sheikh that even in the operating theater, if you want to see the internal opening, you don't have to cannulate the whole fistula. You just put a catheter or cannula inside the mouth of the fistula, and then you inject it and you see through the anoscope or proctoscope, bivalve one for that matter, and you can easily identify the internal opening. Even in patients who had a preoperative MRI done, but at the time of surgery, this I find quite helpful. That is injecting some saline through the external opening and you can see it is coming out. And thereby, if you put in a fine catheter, there is no question of producing a false internal opening. That is very useful, especially for the young surgeons, I must say. Thank you.
Actually, when there is no facility for endorectal ultrasound or MRI, actually junior doctors, they are doing sometimes fistulography, and there is little clue about fistula tract, but still due to suboptimal delineation of the anatomy of the fistula tract, actually fistulography is not recommended.
Okay,
yes, sir. Thank you, sir. All you.
Sir, please. Sir,
yes, sir. Please unmute, sir. Yes, sir.
So sometimes the patient presents with a fistula, the external opening is at the root of the penis. Maybe the midline in the scrotum root of the penis. Then there is a question marks in our mind that whether it has got any communications with the urethra. In those cases, where is the doubt? I do suggest when there is no MRI or ultrasonogram like these facilities, you can do the fistulogram to see whether it has got any communication with the urethra. That is a possibility. Sometimes we face such type of long fistula. Most of the time it is not that, but sometimes the periurethral abscess may have communication also with the urethra. Thank you very much.
Yes, sir. Thank you, sir. It is nicely pointed out that if there is communication with other organs other than anus, it is also sometimes it is shown that it came to the anus and went upwards, and give a misconception that it is a very high fistula. So nowadays it is mostly not recommended, and it is previously told that MRI is the gold standard for fistula evaluation, but nowadays the 3D endoanal ultrasound is coming. So the question to sir is, what is the sensitivity and specificity comparison to?
Sir.
Yes, sir. Sir, please unmute you and.
Tarek, I think sir is not clear. Tarek, please make the question again.
Professor Charles, he wanted to know the comparison between the MRI and your endoanal ultrasound. Probably he has shown the chart.
He has shown this chart.
Yes.
I think the both techniques are quite comparable. I think if you look at Professor Arun's experience with the MRI, he works very closely with the radiologist in the hospital. They provide excellent imaging, and they have very good results with the MRI. So it all depends on who is doing the imaging in your institution. So in Professor Arun's setting, he does all the imagings with his radiologist, so they become very, very good. In our setting, I use the ultrasound all the time. So, there's always a learning curve for every technical modality that you use. The more you do it, the better you become at it. Okay. Now,
you use just do ultrasound yourself, or someone else do for you?
No, I do it myself. Because
that's the thing. If you don't do yourself, you can't rely on the others' report. So it needs a lot of practice.
No, so it's important for surgeons, at least from my perspective, is that when we do the ultrasound and then we bring the patient to the operating room, we learn very quickly what we see in the operating room, and we correlate with what we see on the ultrasound. So there is a better correlation. I think you learn better in that manner. Now, I think I want to point out I want to make one comment to the earlier discussion on fistulogram is that the fistulogram in internal opening is only patent in our experience in less than 20% of the time. So in many cases, when you are using the fistulogram to image complex fistulas, you may not be able to locate the position of the internal opening, but what you are only doing is to delineate all the branches and the ramifications of complex fistulas. And you look at Professor Arun's patterns of fistula, right? You know that they can go in multiple directions. But what you're not doing with the fistulogram is that you may not be able to elucidate the position of the internal opening because it's patent only in about 20% or less based on our ultrasound experience. So the other thing is that when you see a patient with a complex anal fistula, more often than not, you are not the first surgeon who sees the patient, you know. Very often the patient many other surgeries done before coming to see you. And in this case, the fistulogram doesn't give you any information onto the integrity or the situation of the anal sphincters itself. So that's why the MRI or the ultrasound can actually tell you whether the muscle is intact. If it's not intact, how much has already been divided. And I think that's a very important point, especially in today's day and age where you're not the first surgeon to operate on the patient. You certainly don't want to be the first surgeon to give the patient incontinence. So if you already have knowledge that the sphincters are damaged, then you have to be extra careful when you select your next technique to deal with the fistula.
Dr. Chang, I feel very tempted to ask you. In fact, all the three speakers, this question is addressed. What is the incidence of tuberculous fistula in your series of cases? Because you do a lot of complex fistula, and definitely you subject this fistula frag to histopathological examination. What is the incidence of tuberculous fistula? That's number one question. And the number two question, did you ever come across a primary mucinous adenocarcinomas fistula tract without anything in the rectum or colon?
Okay, that's a very good question. So maybe I will go first, and then I'll let Professor Arun and Dr. Parvez Sheikh give their comments. So in Singapore, we have a very low incidence of tuberculosis in anal fistulas, but it's not uncommon. So in my experience, it's probably less than 0.5%. I probably only see like one case in 200 fistulas. We routinely send all our fistula curettings or fistula tracts for histopathology. Now, with regards to mucinous adenocarcinomas arising in anal fistulas, we see this more in patients who have had very, very chronic fistulas for many, many years. So obviously, they are very, very rare. I probably have seen probably less than 5 cases like this in my entire career. But I would probably remember one case very well is actually a young boy who actually presented with a Crohn's fistula. And we treated this, like I mentioned earlier, very conservatively with drainage of the abscesses and with cetons, right? And we left the cetons there for a very long time. And in this boy with the Crohn's fistula, he actually developed adenocarcinoma within the fistula tract, and he progressed very quickly and he died. So they are not common. In my experience, they occur in fistula tracts that have been around for many, many years. But something to think about. And I think the learning point to all the surgeons attending this webinar is that you should always be aware of patients with unusual pathology like Crohn's, tuberculosis, or adenocarcinoma, especially in patients with recurrent fistulas, because they can be the cause of recurrence. Yeah.
Thank you. Thank you very much. And I'm sure you treat this tuberculosis fistula subsequently with antituberculous chemotherapy, don't you?
Yes. So actually, whatever you do in terms of tuberculosis fistulas is that the mainstay of treatment, I think, is anti-TB treatment. But again, I see very little. So maybe, Pabe, you should see more than I do in India. Maybe you can give your comments, and even Mr. Arun, I think you have a lot more.
So about tuberculosis, I agree with you, Charles, that every fistula of mine goes for a histology. It's necessary. Also, medico-legally, it's important that you should do it. The incidence of tuberculosis has certainly come down in India. In Mumbai, where I practice, of course, I see patients from all over the country, but my incidence of tuberculosis is less than 1% what I see. But there are areas in India which have got a high incidence of tuberculosis, that's said. So I think it also depends on where you are working, because India is a big country, so which part of the country that you're working, you would see the incidence. The second part is about mucinous adenocarcinoma. I've seen, I think one I saw just last month, where very typically, as Charles said, that a long-standing fistula, one part of it sort of turns into malignancy, and they're almost always mucinous adenocarcinoma. I've never seen a fistula, malignancy arising in the fistula tract, which was not mucinous. And in fact, if you're operating and you see the mucin, that's what happened last month. This guy was operated a couple of times. They had taken a biopsy from wherever he came from, another city. They had taken a biopsy which was inflammatory. The moment I started coring out, I saw this mucin. Immediately, I called the lab. We did a frozen section, confirmed it was mucinous adenocarcinoma, and then of course, whatever I could do at that time, I did. And of course, now if you have a mucinous adenocarcinoma, it means that you will require an APR. So with neoadjuvant and things like that, and of course they need to be worked up, but they are usually the fact that it's a mucin signet ring carcinoma, that means it's a very fast spreading one, and the prognosis is generally not very good in these patients. I've seen about, I think, around more than 15 cases I've seen of this over the last few years.
I think Dr. Charles nicely mentioned about endorectal ultrasound and MRI. What I want to add something in that, Charles mentioned that endorectal ultrasound, the focal length is only 2.5 centimeter, but when pathology is long track and supralevator abscess or pelvic abscess, in that case, you need MRI. Also, there is endorectal ultrasound is operator dependent, and when you are doing endorectal ultrasound, there is also discomfort for the patient. So in that case, actually, MRI is superior than endorectal ultrasound, I think.
Thank you, sir. Many questions are coming, but we have time constraint and we can't entertain any more question. A very senior teacher and our surgical leader of the society, AZ Mustaq Hussain Tuin sir, is with us. Last comment from sir. AZ Mustaq Hussain Tuin sir, please unmute you and tell a few words for us about the presentation and the program. Sir, are you with us? Possibly sir is not with us. So thanking all the speakers and learned panel of experts. My question answer session is complete. I am closing the question answer session. Now, Dr. Arun, please continue your rest of the session.
Thank you, Dr. Tarek. Actually, we have passed a wonderful time. Meanwhile, by learning many things from honorable speakers, valuable comments from our expert panels, but it is true, we are near the tail of the program. Now, I would like to request our chief guest, Professor Konokkanti Borua sir. We always thank sir for staying with us throughout the program, although his busy schedule. Sir, please.
Thank you, Dr. Arun. Honorable Chairman of the session, legendary surgeon of Bangladesh, our teacher, Professor Mutiur Rahman, and the learned speakers, Professor Arun Rosalanki, and Charles San, and Parvesh Sheikh, and the panelists and the participants, ladies and gentlemen, very, very good evening to you all. I am honored to be present in this August webinar session on complex fistula in ANO. I must congratulate the speakers for their elaborative, informative presentations and interesting presentations also. And I do congratulate them for their wonderful presentations. At the same time, I also congratulate the panelists for their interactive comments and participation in this webinar. At the same time, I also congratulate the participants, as because they will gather the knowledge from the presentations of the speakers. This will enhance their knowledge, and the technical know-how will be has been delivered by the speakers, will enrich their knowledge. I am also congratulating the organizers for organizing such a wonderful session. Thank you very much for inviting me. Thank you all.
Thanks, sir, for your legendary talk, sir. From my side, I again showing my heartfelt gratitude to all the viewers. Finally, I am requesting chairperson of this session for his concluding remarks. Thanks, everybody, and stay safe.
Professor Konakanti Borua, the distinguished speakers, my colleagues, the panelists, I'd like to thank the three speakers, Professor Uru, Professor Charles, and my old friend, Parvesh Sheikh, for taking so much trouble in delivering in such a wonderful speech. I'd like to thank Arun for showing us the lift procedure. The lift procedure about 3 or 4 years back, one of my colleague surgeon, Dr. Shahadat Sen, he explained it to me how it can be done, but I have never tried it. But today, the pictorial description and the demonstration, I think this will be an illuminating for not only for me, but my young colleagues as well, and hope this will help in curing a lot of high and the complex especially. Although there is a certain amount of ambiguity about it, a lot of people think that there is a high recurrence rate. However, probably in course of time, this will pass off. And this rectal flap procedure, the way this has been demonstrated is beautiful. Well, my young colorectal surgeons, I'm sure they will try this one. And I've seen Professor Parvesh Sheikh demonstrating this visually on so many occasions and suturing the sphincters with very good results. I've got a lot of comments for him. And I have a feeling that, as Professor Arun mentioned, the extra sphincter and the suprasphincter, this probably iatrogenic. I agree fully, although Alan Park's description was different. And for the surgeons to be able to do a complex fistula repair, they should have thorough knowledge of the anatomy of the perianal region, and they should be well versed with the MRI procedure. They should be able to learn and identify where is the problem. Our problem is we have got not much of MRI, and not many people are doing it, and so we're not very much conversant with it. And I hope there should be a session on MRI on perineal region so that they can identify the problem and we'll be able to help it. And I'd like to request Shahadat Sheikh and Shahadat and the society to organize this chapter in the near future. I'd like to thank the society for organizing such a wonderful session. I've got one question. What about the glue procedure in repair of the fistula? Will Charles please answer my question? The glue in repair of the high fistula, has it got any scope? Glue.
The results for glue has not been very encouraging. I think most papers would only have a success rate around 10%. I use it in only very few and select cases, insist on it, and only as a last resort in cases where we have failed many other options. But our experience with glue has not been very encouraging. I don't know whether anybody else has anything to share.
What about bioprosthesis?
I don't use bioprosthesis mainly because number one, I think it's a foreign body. Number two is that it's expensive. Number three is that as a lift practitioner and a flap, I find that the results are already good enough. So I don't usually add any further material to improve the results. I know that some people have added bioprosthesis to enhance the results of the lift, not the bio lift. But I don't see the need for it.
So lastly, I'd like to ask Professor Arun, what's your opinion about the laser in repair of the fistula? Laser procedure in repair of fistula.
My colleagues use this. My student use it. But I think the laser is good only for a short, I mean the low transsphincter or low transsphincter. It should be good. For the high one, for the one with the cavity, it won't work. And complex fistula always present to the surgeon with cavities. So there are many cavities in the ischioanal or in the superior. So it won't work in complex fistula for the laser. It works only simple fistula, in my opinion.
Thank you. Thank you very much. Thank you, all the panelists, my colleagues and the surgeons, and my distinguished foreign speakers for taking so much trouble in delivering your lecture. Thank you very much. God bless you. Thank you. I'd like to thank the Society of Bangladesh, Society of Colorectal Surgeons and the organizers. Thank you. Assalamu alaikum.
স্যার কনক্লুড করে যান স্যার, আপনি সেশনটাকে কনক্লুড করে যান।
সেশন তো শেষই, তুমি বলে দাও।
Now we
কনক্লুড হয়ে গেছে।
So we conclude our session over here. Thank you very much.
Thank you. Thank you to the society for inviting me.
Thank you.
Thank you.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.